Good evening. My name is Dr. Ayman Abdel Halim. I'm a pain and palliative consultant at King Fahd Medical City. I'm triple board certified in anesthesia, pain management, and palliative care. I'm going to give you a couple of talks about updates in musculoskeletal pain, followed by updates in headaches. We'll start with the musculoskeletal pain. And I'll start with the quote in front of you on the screen. The case of degenerative disc disease as the explanation of backache must still be regarded as not proven. It is important to treat patients and not x-rays of spine. This quote was basically told to a lot of pain physicians at the beginning of their fellowships. And I still remember them. We're chasing the pain, we're not chasing the x-ray or the MRI. The objectives of this short presentation is to define pain, introduce the mechanisms of pain, and we're going to talk a little bit about pain as a syndrome and acute versus chronic pain, common musculoskeletal pain syndromes, and we're going to conclude at the end with a summary of the presentation. The definition of pain was put forward by the International Association for Study of Pain. And actually, this has been there since the 80s and hasn't changed yet. It's a sensory and emotional experience associated with tissue damage or described in terms of such damage. The only modality in your body, sensory modality in your body, that's associated with emotional experience is pain. To understand pain, you have to understand the slide. Pain is physical and also psychological, okay? As we talked about, it's emotional as well. As you can see on the screen, you have 4 types of pain: neuropathic, inflammatory, physiological, and dysfunctional. The one on the left is basically the non-pathological pain, and the one on the right is the pathological pain. The nociceptive pain, okay, is basically what we call a tissue damage. It's basically a reflex mechanism, so you can protect yourself. Neuropathic pain is a pain in the somatosensory pathway. Inflammatory pain is basically inflammation. It's kind of nociceptive pain, such as, for example, rheumatoid arthritis. And then you have the dysfunctional, and this includes a lot of mechanisms, mainly central and psychological. Pain is actually a syndrome. It starts being an acute problem, and then subacute, then it gets to be a chronic pain problem. As it goes from acute to chronic, you start to develop a lot of psychosocial issues going on. So it's not, uncommon to see patients complaining about anxiety, depression, problems with their jobs, problems with their family, coping skills is impaired. They might have drug abuse problems, substance abuse problem. So you have to understand this difference between acute and chronic pain. Acute pain should resolve with the healing of the causative injury and has a protective biological function to protect against further injury. Protective reflexes include withdrawal, muscle spasm, and autonomic reactions. While chronic pain is a pain that lasts beyond the expected recovery period, and identifiable pathology is insufficient to explain the pain state. It disrupts sleep and normal activities of living and doesn't serve a protective, adaptive function. We're gonna give you kind of a quick review about different types of musculoskeletal pain disorders that's commonly seen in the primary care settings. We can divide them into three categories. The first one is osteoarthritis, the second one is inflammatory arthritis, and the third one is septic arthritis. And the osteoarthritis can be divided further to primary and secondary, while the inflammatory arthritis include rheumatoid, psoriatic, crystal-induced arthritis. Septic arthritis is a life-threatening problem that we see every once in a while. And as a clinician, you should be able to identify it early on. Primary osteoarthritis is a chronic disorder associated with damage to cartilage and surrounding tissue, associated with pain, joint stiffness, and loss of function, and can be confirmed with physical examination and X-rays and MRI. There is no serology test for primary osteoarthritis, but you can always do a joint fluid aspiration. Secondary osteoarthritis versus primary osteoarthritis. Secondary osteoarthritis is related to a secondary disease such as obesity, trauma, congenital anomalies, gout, and so forth. While primary is related to aging, mechanical stress, and there's a genetic component to it. As you can see with X-ray, you can see this osteophytic changes and sclerosis in the subchondral area, and also the narrowing of the joint space, usually in the medial compartment of the knee. Rheumatoid arthritis, on the other hand, is an inflammatory disease. It's an autoimmune condition. Pain and stiffness on walking or inactivity. There's always a systemic involvement and can be diagnosed with symptoms, serum rheumatoid factor, and X-ray. These are some of the criteria of the American College of Rheumatology that are used to diagnose rheumatoid arthritis. So as you can see, arthritis of hand joints for at least 6 weeks, arthritis of both sides of the body for at least 6 weeks, rheumatoid nodules. We're going to show you a picture in just a second. Rheumatoid factor in the blood testing, and morning stiffness at least 1 hour. This is compared to osteoarthritis, which only lasts up to 30 minutes. Arthritis of 3 or more joints for at least 6 weeks. Evidence of rheumatoid arthritis on X-ray. Rheumatoid arthritis go into stages. First stage, which is, we call it the early stage. You can see it's just mild inflammatory disease, followed by the intermediate stage, and then later on, you will get all these kind of deformities, classic for rheumatoid arthritis, like the swan neck joints, and so forth, the ulnar deviation, very commonly seen in late cases of rheumatoid arthritis. And this is just a picture for the rheumatoid nodules, very significant, as you can see. This is an X-ray for rheumatoid arthritis patients. As you can see, it affects certain joints, like the MP joints, the metacarpophalangeal joints, and the proximal interphalangeal joints, and also can affect the wrist joints. This is compared to osteoarthritis, which affects the distal interphalangeal joints and the proximal interphalangeal joints, and also the carpometacarpo CMC, carpometacarpal joint of the thumb. So just by looking at the patient, you can easily identify the condition. There is a special case of rheumatoid arthritis called the Felty syndrome. And basically, it has a mnemonic, which is Santa. And this is, I mean, we're in the same kind of wavelength. We just passed the Christmas a few days ago. So the condition has 5 items here: splenomegaly, anemia, neutropenia, thrombocytopenia, and arthritis. You see it more in adolescents. Then we're going to shift to another category of arthritis conditions, which are called the spondyloarthropathies, the most famous of which is the ankylosing spondylitis, psoriatic arthritis, reactive arthritis, enteropathic arthritis. All of these diseases basically have a negative serum rheumatoid factor, while they have a genetic link with the HLA-B27. This is a picture for for ankylosing spondylitis. The patient develops stiffness mainly in the spine and the sacroiliac joints. There's a very famous test called modified Schubert test, where you can mark somewhere between L4 and 5 and mark 5 centimeters below, 10 centimeters above. And then allow the patient to bend. If he's able to extend his spine beyond 21 centimeters, he does not have ankylosing spondylitis. On X-ray, the spine looks like a bamboo spine. Very famous, very classic for ankylosing spondylitis. At the beginning, actually, these patients, they will have a tremendous amount of pain. But as all the ligaments and disc and everything gets fused, the pain gets better. But of course, they will have a severe functional impairment. So we're going to shift to another condition, which is called psoriatic arthritis. Psoriasis is a very common and famous skin condition characterized by this silvery, scaly eruption on the skin. A lot of these patients, they have arthritis associated with their skin condition. And as you can see, they develop this sausage-like arthritis in their fingers, what we call dactylitis. Very, very common to see this with psoriasis. Another condition is called reactive arthritis. It used to be called Reiter syndrome. Basically, is a constellation of 3 conditions: urethritis, conjunctivitis, and arthritis. There is a very famous quote here that I like you to remember. It will remind you with the reactive arthritis. Can see, can pee, cannot climb a tree because of the three conditions they have. Sometimes it's post-venereal and related to an infection with chlamydia. Also, it's associated with HLA-B27 like the rest of the spondyloarthropathies. This is just a comparison between rheumatoid arthritis and spondyloarthropathies. As you can see, rheumatoid arthritis are symmetrical appendicular, small joints of the hands and the feet, while spondyloarthropathies are symmetrical, axial, asymmetrical, large appendicular joints. So they show up more on the big joints and on the axial spine, and sometimes it's asymmetrical. Also, the spondyloarthropathies are associated with enthesitis and dactylitis, and a strong HLA-B27 association. They have rheumatoid factor negative. On the other hand, rheumatoid arthritis, you don't see this HLA-B27, but sometimes you have HLA-DR4 association with positive rheumatoid factor, and nowadays we do also what we call anti-CCP marker. The treatment of rheumatoid arthritis is either chemical or biological DMARD, disease-modifying activity of rheumatic diseases, while the spondyloarthropathies is usually biological. We're going to jump into another common condition, which is gout. It's commonly found in men, much more than women. It has a genetic predisposition. Basically, they get inflammation in their big toe, secondary to uric crystal deposition. The serum uric acid doesn't help you that much. Sometimes patients have high uric acid and sometimes are normal. The main diagnosis is through joint fluid aspiration. It is associated with what we call tophi in the skin. You can find it in the ear, in the elbow. This is an X-ray picture for gouty patient. It's very painful condition. This is some of the food that they should avoid. And of course, one of the mainstay treatments for maintenance is allopurinol, which prevent the uric deposition as a prophylaxis. And NSAIDs for treatment for the attack, like, for example, endomethacin or whatever other NSAIDs available. Every clinician should be aware about this condition, septic arthritis, because it can actually lead to rapid joint destruction and serious cause for mortality. It could be direct, the mechanism could be direct inoculation, or it could be bacteremia. As you see, the pathogenesis could be different things, including endotoxins, exotoxins, tumor necrosis factor, interleukin 1 and 6. This is how it looks as far as septic arthritis. This is a medical emergency. If you're confusing it with another inflammatory condition, you should get an aspiration and get a complete blood picture to see whether the patient has leukocytosis or not. The treatment, of course, is basically antibiotics. We're going to shift gears to low back pain. As you see, it's a very common problem. At least 5% of the population in the US, they're suffering from low back pain every year. And it creates a lot of burden on the work, because a lot of these patients, they get sick leaves, and almost all the doctor, 3% of all doctor visits are related to low back pain. These are common causes of low back pain: muscle sprain, strain, herniated disc, degenerative disc disease, annular fissure, zygophyseal joint arthropathy, which we call facet joint disease, spinal canal stenosis, either central or foraminal. Osteoarthritis of the hip can refer to low back, spondylolisthesis, and ankylosing spondylitis. These are rare causes, but are pretty serious ones. These are red flags: epidural abscess, discitis, osteomyelitis, metastatic cancer, abdominal aortic aneurysm can give you a vague low back pain. And I want to say that I've seen all of these in my practice. I've seen the patients with discitis. This is a pretty serious problem. I saw the epidural abscess, I saw the metastatic cancer, and I even identified a patient with abdominal aortic aneurysm. And I saved him from a very extensive workup on his back by just looking at, with an ultrasound, we found this abdominal aortic aneurysm. You have to be aware about these conditions because these are emergency cases. Just to give you some of these, conditions, famous ones that we see in our practice: lumbar facet, which is around 20% of all cases of low back pain; sacroiliac pain, also 20% of all cases of lower back pain; herniated disc, especially the L5 and S1 radiculopathy; myofascial pain syndromes, very common: piriformis muscle, iliopsoas, and quadratus. And that's why we send a lot of patients to physical therapy to help us with these conditions. And sometimes we inject these muscles with local anesthetics or do even acupuncture to release this tension in the muscles. Sports injury is also a common problem. It can happen in different areas, including the knee, the thigh, and the ankle. You can see it in different muscles like hamstring, calf muscles, quadriceps, and groin. Injury rate is somewhere between 69 to 118 injuries per 1,000 playing hours. Early treatment is essential. So if you see any of these folks immediately after the injury, please remember the RICE protocol. Rest for 48 hours, ice for 20 minutes at a time, 4 to 8 times per day, compress to help reduce swelling, and elevate the injured limb 6 to 10 inches above the heart to reduce the edema accompanied with the injury. This is just a general slide for management of musculoskeletal problems. I always explain to the patient when he or she comes to the clinic that we have 5 things that we can do for him. The first one is behavior, like, for example, a stress reduction, for example, meditation, and so forth. Physical therapy, we can send them to the therapist. We can give them medications, pharmacologic techniques. We can do injections, and we can send the patient to surgery if needed. Remember these 5 things. A lot of times the patients, they're not aware about your job, duties. They kind of ask themselves why why he's here or she's here. So you have to explain to them your role in the treatment. Nowadays, we do a lot of these techniques called the regenerative injection therapies. Okay, we use dextrose, or we use what we call platelet-rich plasma and stem cells for sports injuries. Platelet-rich plasma is basically you pull blood from the patient, and then you put it in a centrifuge machine, and then you concentrate all the growth factors, okay, in the upper part of the tube, and you inject them in the injured area. We do a lot of these in King Fahd Medical City, and with a lot of success. It kind of repairs these ligaments and tendons and cartilage. It's a healthy choice for degenerative joint disease. Another way to do it is stem cells, by aspirating through the posterior superior iliac spine, or through aspirating the adipose cells from the abdomen, and then we inject them again. Sometimes we mix the stem cells with the PRP. These are the phases of healing: inflammation, proliferation, and then remodeling. So at the end, we're going to conclude our presentation with the definition of acute pain, which resolves with the healing of causative injury and has a protective biological function. While chronic pain is, in fact, a pathological condition, it doesn't serve any protective or adaptive function. Musculoskeletal pain and sports injuries are very common form of pain. Simple analgesics such as NSAIDs and paracetamol are considered the first line of defense. And these are the references for my short presentation. Thank you so much, and have a good day.